Please
So
go ahead.
welcome all those who choose to share this time with us here on discussing all our speakers who are going to discuss the various paths that they take in achieving consistent results in phacoemulsification. Our first speaker is Dr. Navneet Toshniwal, who's going to speak to us about phaco in different varieties of cataracts. Light kam ho sakti hai yahan pe? Nahin, no?
Respected chairperson and colleagues, please start the video, sir. Phaco in a variety of cataract. In 7 minutes, we will try to see some important condition, that is a soft cataract. Hydrodelineation is very important to see the size of nucleus. That is very important. If it is very small, size is less than capsular axis, not very hard, even a visco expression is very important to remove these cataracts. Now another condition in a soft cataract, when you do the hydrodelineation, multiple rings delamination can occur, and you try to see that whether this size can come out or not. And this is very important. And then I try to say manure that whether I can able to lift this nucleus or not, but no, definitely not. And then very important, again we will go back with the stop and chop technique, try to remove some of the epinucleus if it is not give the good view, and central trench, that is the most important, not really very deep, adequate depth. And this is this topic is the instrumentation which assists you in your surgery. So this is the Toshniwal pre-chopper. It is a typical design instrument, give the equal pressure on 2 halves of the nucleus. Why it is important? Because soft cataract, if you think of the divide also with the small instrument, you can see that the instrument can pass through the substance. So it is not very easy to divide these nucleus, and then you can do many ways. You can do flip chip, you can go, try to hold, try to suck it out, do with the vacuum, many things. But if you want to go systematically, you should have the instruments with you, that is the pre-chopper. So that's why that was a demonstration. Many times hold is very difficult, so after this we can take the decision of half piece has been delineated and visco express it out and remove it out. So this is a very simple way to see this soft cataract, because these are the challenging situation. Now see the other eye. What is the significance of hold? It should be very, very slow, not fast. We have to go from one plane to other plane. So here, although it is a slow, minimum parameters, very important. In Jordan, I was doing live surgery. I could not hold the things. Alcon guy was there. This is story of 2008. Suddenly he increased the parameter because there was no hold. Then we have to cut down the hold. Parameters, these are very important point. So knowledge of, our knowledge is also important to tackle this simple situation. Then visco expression, why methyl cellulose is very important. In European community, they don't get the methyl cellulose. They are having the Hilon, GV like this. But methyl cellulose is such an important, when they come for training at our center, we can show them how this simple product is so useful. And you can see here how the visco expression, because this is a bulky mass, you do with the coaxial, you do with the bimanual, still it is a very simple is the visco expression. In mature cataract, I am just showing the very simple. This is the Toshniwal microcapsular axis forceps, designed by me, by Sunaina Surgical and Seagull Optics also. So make a small neck. This is very important. Complete axis is important. Then you can do the debulking of the tissue. Many times we see in the presentation, they just take one nick and they try to aspirate. Out of 50 cases, 5 will run away. So complete capsular axis is very important. And then again the use of the Hilon like things or whatever dispersive you are using, how to put, where to put, how much quantity we have to put. This is important. Another instrument is the micro Caesar, that is also designed. It is by Seagull Optics, and we are completing after debulking. It is a very different, unique design according to the anatomy. So that will assist. I generally don't do hydrodelineation, dissection, no need, because you cannot go in the correct path, correct plane. So directly start with the stop and chop technique. Here you cannot predict what depth, but again a pre-chopper is very important, and once it is equal division, your job is easy. And lift it out, again lift it out and use at a plane of a capsule, remove it at a plane of a capsule. So instrumentation definitely makes the difference, although these cases routinely we are doing. Now hard cataract. Again a stop and chop technique. Definitely there is no space between capsule and the lens, so I don't do more hydro. In these cases also, just go with the trench. When you are doing trench, indirect hydro is going on. Unintentional hydro is going on. Here the most important step is the division. And that is the reason you have to practice, you have to understand what is this. Now see, we are trying to divide, it's a leathery structure, not very easy, but because of the pre-chopper, you can take the chance 1 time, 2 times, 3 times, equal pressure on zonules all the times. So that's not damaging the zonule, that is very important. Slowly, this is another very important, many times we have to do in situ, but I try to bring at the level of capsule, I try to bring at the level of iris plane, and then chop we can do. Another very important point I want to highlight, many times in a hard cataract we are using fancy choppers. I think it is not really needed. It's a very simple chopper we are using, modified Nagara chopper. This is also with the Epsilon, that is a Toshniwal chopper, and hold is very important. If you hold nicely, then you can chop. Partial chop is a very typical idea, typical point. You can do the partial chop and we can do.
So your time is up.
Yeah. So these are the different ways we can do the nucleus emulsification in different variety of cataract. Thank you for your patience hearing.
Routine Akahashi chopper. What is
I have done the Nagara chopper is a straight shaft.
Okay.
I have make is a corneal, parallel to cornea.
Curve.
And the vertical distance I have cut it little bit less, so that it is a modified.
Is it
That's
patented and it is a financial interest?
patented? No,
No
but
patent.
they are Toshniwal chopper as in Epsilon stall. Yeah.
Can I
Thank
ask another question?
Yes.
When you're looking at a rock hard cataract or a fairly hard cataract, grade 3 brown and above, do you not find any meritosity? You mentioned if you get a good hold, you can chop. Do you not think a sharp tip chopper makes this mechanical split easier?
Definitely. It will make the things definitely, but there is at the same time there may be risk with these sharp choppers. And that is the reason clinically what we say, if your hold is strong, and which is very important,
Correct.
hold if is excellent, you just touch, it will chop. And then I mention it is a partial chops. I am not interested to do the complete chop. So partial chop will make the sense that you can eat the piece, that base, again you can catch the other material.
A multi-layer
That is the way. Thank you.
Very well
Thank you
presented.
very much.
Thank you so
very
much.
much. Thank
One more point was during your visco expression of the soft nucleus, we can go with the bimanual and with the aspiration go to the main port, just tip it a bit down on the main wound and the epinucleus also comes out.
Exactly.
Yes.
Thank you very
Thank
much.
you.
Thank you.
Okay, next speaker, Phaco in soft cataract, Jitendra Vidani.
So while he gets started, I think we'd all agree that managing soft cataracts is often far more unpredictable and far more challenging than managing cataracts with some amount of density because we can predict the way they go. So it should be interesting to listen to Dr. Jitendra share with us his take on how he manages soft cataracts.
Dr. Rajendra Prasad is here. Yeah, I didn't see him. I was looking for him in the first time.
Shall start, ma'am? Okay,
Please go
so
ahead, sir.
good evening, everyone, and thank you, AIS, for this wonderful opportunity. And KMCHO and greetings from the land of peace and growth. And without wasting much time, I'll start my talk. Case 1, 33-year-old male patient, right eye amblyopia with PSC grade 1 cataract. Right eye vision was finger counting 3 meters, left eye vision was 624. Left eye was operated 1.5 years back. Guarded visual prognosis consent was taken since the patient was amblyopic. So large rexus, here I am doing the double rexus technique because I feel that I am more confident doing that in every case. And the rexus should be appropriate sized in soft cataracts especially. Hydrodissection and delineation is done and the nucleus pops out. And I was pretty happy to see that and did not try and put it back inside because I was just hoping that it comes out automatically, and then I was able to emulsify it because the nucleus had already popped out. And since there was good hydrodissection and delineation, I could complete the case easily. The emulsification was done and then the cortex aspiration was done. Moving on to next case, 60-year-old female patient, diabetic and hypertensive since 10 years. Right eye was operated 1 year back. Right eye vision was 6.6, left eye vision was 6.9, and left eye grade was soft cataract grade 1. So here I'm trying to do the soft stop and chop technique, which I was successful in doing the first primary chop. I could divide it in 2 heminuclei. The parameters were very low. I had just used vacuum in this. The power was very low. I think it was 20 on the machine, and the machine that I used was Alcon Infinity. So I'm able to chop it, but there's one point where I'm not able to chop it, so I shift my technique to trench and divide, and then try to divide it, so I'm able to do other chops. And then in soft cataract, as soon as just one piece comes out, the rest of the surgery becomes a cakewalk. Next case, 51-year-old male patient, right eye grade 1 cataract, vision was 624, left eye vision was 618 parts. IL power calculated was plus 20.5 diopters, a little on the myopic side. So again in this, the initial chopping was done with stop and chop technique with low parameters, and then I was not able to do another. You can see that there is cheese wiring, right? So then I shifted my technique to trench and divide. Again, then I was easily able to do it in 2 heminuclei, and in soft cataract, even the heminuclei, if you're able to chop it in, then you're able to remove the nucleus very easily. And then I could remove the epinuclear plate because there was a good hydrodelineation. 44-year-old female patient, right eye vision 624, left eye vision 6.9, right eye posterior. It was kind of a PSC cataract, but I considered it as a pseudo posterior polar, and the IL power was plus 17 diopters. And I wanted to treat this patient as a posterior polar cataract, which I'll be demonstrating right now. The technique that I'm following is was introduced by Dr. Abhay Vasavada, that I've just followed the inside-out technique. You use the probe, you create a trench, and then you just put your hydrocannula and just delineate it. So the nucleus gets divided into multiple parts, and then you're able to emulsify it pretty easily and safely. And the epinuclear plate was there, which I could then remove it with the phaco probe itself. But since I wanted to treat it like a posterior polar cataract, I used visco. I did not withdraw the instrument, and visco hydro replenishment was done. So this is the article that Dr. Vasavada had published for the inside-out technique. 46-year-old female patient, both eye vision 624 improving to 6.9 with pinhole, left eye grade 1 to 2 plus PSC cataract, IL power was plus 25.5 diopters. So this case went like haywire. I tried each and every technique, but I mean, the gods were not kind to me at that time. I guess it was not my day. So there was cheese wiring, there was a bowl formation, And I was just looking at my father and wondering what should I do now, and he was looking at me that I don't have any idea, you go ahead and do it. And then I just had to go ahead and devise a technique where I was using the chopper in one hand and the iris depositor in one hand. I'm just trying to prolapse it in the anterior chamber. And I was there at Dr. Saurabh Patwardhan's hospital this year. He calls it the dish technique, do it somehow. So this case was actually a dish technique, do it somehow. But once the nucleus comes out, soft cataract rewards you because then you're able to remove it easily. So soft cataract, my polls, soft is actually harder. Accept it first of all. Do an appropriate sized rexis. Use a good dispersive OVD. I use Viscoat, no financial interest, to protect the endothelium, and a good cohesive OVD. I use Helon, again by Alcon, but no financial interest, to protect the posterior capsule. Hydrodelineation is a must. Have multiple techniques in your armamentarium. Always attempt chopping first if possible with low parameters. That is what I do. Trench and divide if that's not possible. And hydroprolapse is also not a bad technique. Some surgeons consider it that you should not emulsify it in anterior chamber, but I would disagree, because if you're using a good visco, you can always go ahead and do it and it will not damage the endothelium. Inside out can be attempted not only in PPCs but also in soft cataracts. It works well in my experience. And if nothing works, in case of cheese wiring or bowel formation, as we saw, dish technique is the ultimate technique. And last but not the least, have patience and keep it in mind. It's not over until it's over in soft cataracts. Thank you.
Well done. So I have just one comment. To me, the dish technique, in fact, the beginning technique, the ending technique, and a dish technique in any nucleus that is not too soft to chop would just be a simple hydroprolapse. Once you bring it in the AC, that manjan of sculpting, you get too deep too soon, chances of getting to the PC, or you get a bowl.
Yeah.
Either at the beginning, or suppose you got a bowl. Now in a bowl you already have a very thin plate. Or kya sculpt karoge aap?
You can't.
So what would be your dish technique if you had a thin paste bowl?
So ma'am, if I have a bowl formation and I have an appropriate size axis, then my go-to technique would be prolapse it. Because I've already used Viscoat. So I know that for sure that this patient is going to be crystal clear cornea next day. So I would prolapse it.
Also
One more.
Also, you see, you hardly use any energy.
Correct.
You
That's
hardly
what,
need
yeah,
any
absolutely,
energy.
it's on
Correct.
aspiration.
So hydroprolapse is pretty legit and
So
safe to
one
Works
more
well for
thing
me,
that
works
could
well
be done is flip the plate into the anterior chamber. Just flip it up. Yes, flip it up with the dialer.
That's also an option if you're left
Yes. With the plate. Which one?
Yeah, correct. So I do that. I go
Yes.
behind the
And then
nucleus
just-
and then put Helon, so
just
that I'm
rotate
very
it-
sure
rotate it and
that
get
it's
it
a
into
heavy
the
visco.
AC.
So the posterior capsule will not be damaged, as well as it will come up. So I do that.
The challenge is if you have an unbroken bowl and a rexis that's not too big. When you have an unbroken bowl and a rexis that's not too big, it is dangerous to go with a dialer to hook onto the nucleus and bring it up.
No, you flip it.
Ma'am, I have a
Over the
question.
plate.
इसके नीचे जाना पड़ेगा ना?
ऊपर नहीं, ऊपर से. It is ऊपर से.
Ma'am, I have a question.
Fair enough.
So if you have
So
a bowl
this-
formation,
Yeah.
This is the thing. Just go up. Don't go below.
Okay. Question.
if you have a bowl formation, and the rexis is not appropriate sized, then what do you do?
I would still decompress the anterior chamber, remove some viscoelastic, because whatever else I do after that, I don't want the PC blowing out. Once I've got a soft tie with very little visco in it, I will still go back in and do a hydroprolapse. It will prolapse out. Try it. Thank you. Thank you
you so
very much. Extremely well presented.
Thank you, ma'am. Thank you, ma'am.
Good afternoon, sir.
You want to call Dr. Lahane first?
So, would you like to speak now, or shall I get you next, sir? Next, एक और, ठीक है. We now invite Dr. T.P. Lahane, sir, to present his paper on the intumescent cataract. All is well.
So I am presenting the intumescent cataract. Thank you, everybody. Sorry for the late because there was another presentation there. So, this is about the intumescent cataract, and here the no financial interest. There are few challenges when you go to the intumescent cataract because there is absence of fundal glow. You can see the extension of the rhexis, then posterior capsular rupture, nucleus may drop and endothelial damage, or you can say the decentration of the IOL. So all this can be taken care by some of the steps. You can just change it, and then you can definitely overcome such type of complications which happens in the intumescent cataract. Now this is the cataract I am doing. You can see the central, there is a opacification, and you can see the fluid, and this is the intumescent type of cataract whenever you are cutting. Now what happens is there is some fibrosis there. So always whenever you are starting the rhexis, it should be away from the fibrosis, otherwise that rhexis will get extended. So whenever you are doing, and when you will see the rhexis is extended, here you must use the forceps instead of using the needle. So that forceps will definitely help you, and again you will have to recapture, and after that also it may extend beyond, because the fibrosis, the rhexis will go till the fibrosis is there, unless and until it is a femtorrhexis. The normal rhexis can be extended in the fibrous area. And now see here I am doing it, but there is no buttress. It means no epinucleus or no capsule, this cortex. So here I am doing the you can say the horizontal chop, and in the horizontal chop, see my tip of the this is, you can see it is a blunt tip. That at the tip my chopper is blunt, and I am doing the horizontal chopping. So this horizontal chopping is only possible, and you will have to go properly. Otherwise, what will happen? The piece may tear the posterior capsule. So go slow, and whenever this piece is moving, because no support there, and so piece moves, and when there is a last piece, in that the chopper movement and also your hour parameter should be less, and then you do gradually it so that surge will not be there, and that finishes the such type of surgery. The other case is, again I will show you you can see this, the intumescence, you can see the fluid also. So here there is a fluid in the cataract, there is the subcapsular, you can see here. I am doing again the rhexis, and after you can see this is what I did, the rhexis in this, and it is stained capsule, but you can see the fluid. So that can obscure your vision, but still gradually once it is seen, you can remove, or otherwise you can stop it and just you can aspirate the fluid, and after that you can do. Now see this, I am using the forceps, and after that I could complete the rhexis, and you have seen so much of the fluid is there, and after that fluid, now this is you can say brown cataract. So before that you were thinking that it is a white cataract, but this is a brown cataract now, and when I am going in, you can see here I am going inside, and once I am going inside, then again you will see here, so tip, that is a phaco, I am going in, and after going in, I am trying to separate, so up to the center of the nucleus. It's very, very important. Whenever you are doing it, you go inside, your chopper is in the periphery, you see here, and then you can separate it. So now this such type of nucleus, there are no posterior leathery fibers. It is a white cataract, and because of that, here the chopping is easy, because here you can do the chopping, but you will have to stabilize the nucleus and use both, that is a phaco tip and also your chopper, and stabilize that piece and then cut. So once you stabilize, then it is possible to chop the piece. So I am stabilizing and chopping the piece. Again you can see this I have and once it is completed, can you see this? The last piece, always remember, you will have to be very conscious for that. So that finishes the surgery there. Now this is the another another cataract. You can see here the hypermature cataract. Can you see this? So it is moving. The zonules are again, in this case, they are very, you can say, loose, and in that I am going inside and trying to do the, you can see this, aspirate the fluid behind, and that I have reduced the, can say, the pressure on the capsule by just aspirating. So you can aspirate and then again I am going in, but cutting is not possible here. Again you will see here, because the lens capsule, here you will see it is a fibrous lens capsule. Can you see, whenever I am doing it, it will come with me. It means with my this needle. So now I am doing it with the forceps and catching and re-catching. Lastly I could do it and remove it. So the last, now my time is finished, but this is also hypermature cataract. So basically what I want is a take home message. Dye for the capsular stain, then the sharp tip and the chopper. Always see that it should be a new tip. So don't use the old tip. Then a stop and chop technique in the nucleus, but in hypermature maybe you can say chop technique. Effective use of the ultrasound, and choose what is effective in your hand. Thank you very much.
Next speaker, while chopping when cataract doesn't crack, Dr. Rajendra Prasad, sir.
Hello, sir. How are you? No, thank you. One thing about staining the anterior capsule in hypermature cataracts is you have to give a longer time of different blue staining, because usually we are in a hurry and we try to wash off the different blue earlier. But in hypermature cataracts, it's better to wait for a minute or so and then you go on for your capsule. It doesn't matter if it is navy blue in color, it will wash up ultimately.
Thank you.
So one point about
Good
Dr.
afternoon, and chairpersons and dear friends. I'm going to present rock-hard cataract management pearls. And we know that whenever you come across with these rock-hard cataract, the most important thing is you have to crack the nucleus. But many times you are not able to crack, then the whole problem starts. And if you look at these rock-hard cataract, they present to us a series of specific and difficult challenges during the surgery. And these challenges are primarily because of the dense, the hard nucleus, very weak zonules, very weak capsule, and there is always an absence of the cortico-epinuclear buffer behind the nucleus. The nucleus essentially sits on the weak and posterior capsule. So everything is difficult, and the cracking becomes so difficult in these cases. Whatever technique you use, many times, because whenever you are using these chopping techniques, you don't get the complete crack of the nucleus. And you can see in these videos, I'm just trying to crack the nucleus with horizontal, vertical, right and left, any technique. Whenever you have a very, very solid hard cataract, you are not able to crack them. And if you are not able to crack the nucleus, you will not get the free pieces for emulsification, and then you'll tend to use more and more phaco energy and more manipulation, and that could be deleterious to the endothelium and the posterior capsule and the adjacent structures. So whenever you come across these rock-hard cataract, you need to follow these 10 pearls before starting the cataract surgery. In these cases, you need to have a good preoperative examination. You should know your case, what kind of case you are dealing with. You should have a good pupillary dilatation, at least 8 to 9 millimeters of pupillary dilatation. Your capsular axis has to be perfect. It should be continuous and complete capsular axis of at least minimum 5.5 millimeter to 6 millimeter of capsular axis. You should use very highly retentive viscoelastics in the capsular bag in the anterior chamber. And your hydro procedure is very important, because whenever you're coming this hard cataract, your hydro procedure has to be limited and very controlled hydro procedure. So that is another important point. And the next is your nucleus management. You can use any of these chopping techniques, but I prefer my own technique that is called as a terminal chop technique. Your machine settings are also very important. Be prepared with your hooks, rings, CTR and 3-piece iron always with these hard cataract. And you should know when to stop, when to convert. So that is very important in these hard cataract, otherwise you may land up with the serious complications. Your chopper selection is very important, because the chopper takes up the best part in cracking these hard cataract. This is the chopper I use in my cases. This is called as a terminator, and this is the triple edge chopper, which gives you a good cracking in these hard cataract. So I'll just show you this first case of rock hard cataract, and you can see the dark brown nucleus. The important point in these cases is your incision is very important, because you have to have a comfortable incision and good size of the incision. It should be a valvular incision. Always stain the capsule and use good viscoelastic before you start the capsular axis. Your capsular axis, as I said, should be at least 5.5 to 6 millimeter, and it should be complete and continuous. You should not have any extension of the capsular tear in these cases, because we'll end up with the capsular tear, extension of the capsular tear, then you will have a problem in cracking these nucleus. So have a good large capsular axis. Your hydro procedure has to be very limited. Inject very slowly and very limited fluid, because you should not have a cortical cleaving kind of hydrodissection in these cases. It may blow out your posterior capsule into the vitreous, and your nuclear rotation has to be confirmed before you start the cracking procedure or doing any of these chopping procedures. So this is the chopper I use. And as I said, and your phaco tip has to be at least 2.5 millimeter open, and good phaco tip, sharp phaco tip, and this is the chopper I'm using. And as you can see, because how you can crack these nuclei, I'm using here my technique, terminal chop technique. You have to just penetrate from the center and go towards the equator, just see the edge of the nucleus, just hook it completely, and then crack it here. So if you crack at the equator, then you'll get a complete cracking. Because if you try to crack at the center where the nucleus is very bulky and large and hard, you won't be able to crack the nucleus. So start from the equator to crack the nucleus. As you can see here, you have a complete 2 pieces of the nucleus. And I'm again starting from the periphery, and this is the first heminuclei broken into pieces. And you see, because if you have these free nuclear pieces, your emulsification becomes so simple, and you can use minimum energy and minimum manipulation to emulsify these free nuclear pieces. And as you can see here, this is the free nuclear heminuclei. Crack it again, and you can complete the emulsification very simply. And you could see, because there's such a hard cataract, your cornea is looking absolutely clear, the capsular bag is clear. And this is the another case, and as you can see, this is the cataract nigra, very, very hard cataract. Again, I am using the same technique here to crack these nuclei. And this is the chopper, because I'm trying to slightly pull the nucleus, see the edge, and then crack it. And you see, because if you are hooking it completely, you get a complete cracking, means even the posterior plate is broken, you get a complete free segments. So first heminuclei is being broken, and you have now completely free segment even with this kind of cataract also. This is what is important in these hard cataract. You must get a complete free segments, at least 4 segments. If not, you can take at least up to 6 segments emulsification for the emulsification. So this is the first piece is gone, and then you can take up the second piece for emulsify it. And the second heminuclei, because you see the position of the phaco probe, you don't go deeper, because you don't go deep into the center of the nucleus. Go superficially towards the equator, then hook it, and then you can crack it. And I have 1 minute more.
Yes.
So this is the last case I will be showing. This is another hard cataract and almost grade 6 nucleus, brown, dark brown nucleus. And you can see, because how my phaco probe is going, and see the edge of the nucleus. Now this, as you can see, because this is just the tilt, I am not pulling the nucleus, because there is no pull effect on the zonules at all. It's just the tilt, because if you hold the nucleus at the equator, you can simply move the nucleus up and down. You can tilt, and then you see the edge of the nucleus, and then hook it completely. The most important is you have to hook it completely. If you hook it, you'll get a complete fracture of the nucleus. So this is how you can get the complete fracturing of the nucleus. And then once you have a complete fracture, these 3 segments you can emulsify, and you can go ahead with the implantation of the choice of preferred. So whenever you're dealing, to conclude, whenever you're dealing with the rock hard cataract, the surgical technology and technique, whatever you're using, should aim. You have to generate least energy into the anterior chamber so that you protect the endothelium. Minimal manipulation so that you protect your zonules and the posterior capsule. Minimal strain on the zonules. That is very important because many times you land up with the zonular dialysis, and while protecting the corneal endothelium, zonules and posterior capsule is the most important point. Thank you.
Excellent presentation. So I have a question. Sir, is there any time you get a chance, a situation, even when you use your technique, that you may need to still do a multi-layered job? Or does it always split all the way to the posterior plate? Because sometimes they are very, very thick.
Yeah. See, actually this chopper, the tip of the chopper is quite long. And the important point is because the tip is not sharp. The tip is not sharp. The tip is very long. And the tip is ball shaped. It's an olive tip. So you can freely, without closed eye, you can hook it. You have to hook it completely. The tip is very long. Whatever is the thickness of the nucleus, you will be able to hook it completely. Hook it and then crack it.
So to master your technique, it has a learning curve. So
Very little.
sometimes tilting the nucleus, sometimes you're scared.
I'm telling you one thing, because horizontal chop and vertical chop,
Yes.
I started with, and it took very long time for me to exactly learn. I don't think even today, many of the people, they are not able to do. I've seen live surgeries.
It's very
they
scary.
struggle with the horizontal chop and vertical chop. I also struggle. But with this technique, the learning curve is so less. See, simply you have to hook the nucleus. The hooking is, there is nothing learning in it.
Yes,
you
sir.
just hook it and crack it.
Is hooking possible with only your chopper?
Hooking has to be done with this chopper only, because if you
With
use
this
sharp
chopper.
or thin chopper, then you won't be able to hook it.
Correct.
It's a hook shaped chopper.
Thank you. That's
What
an
type
excellent
of
innovation.
energy you are using for the
Yes.
Energy.
which energy you are using for removing
Energy.
the pieces in the
Energy,
hard cataract?
phaco
Yes.
energy.
Yeah.
You're talking about the phaco
Modulation. What modulation?
Phaco energy, I'm using white star actually, because there's most mother machine white star. But as I said, for cracking, it's not the phaco energy. I don't use any phaco energy rather for the cracking.
One more thing is hard cataracts is better to trench, divide and then conquer, to be on the safer side.
I'd like to now invite the next speaker, Dr. Bharti Kashyap, who's going to speak to us about a triple problem dealing with pseudoexfoliation in a hard cataract with an associated preoperative astigmatism. Dr.
Yes, thank you. So good evening everyone. And my topic is pseudoexfoliation cataract with glaucoma needing toric IOLs, shooting the triple problem. Basically we all know that in pseudoexfoliation there is astigmatism, there is glaucoma, then whether to do phaco trap and toric IOL implantation at the same go, or we should delay the toric IOL and first do trap. So I'm going to discuss on that how we can do it in one go. And we have done a study, and as time is less, so I am going to fast forward few slides because I have to show my study. So there are a mnemonic rule to remember frequent signs in pseudoexfoliation. It's a dimple. Dimple is accumulation of dandruff-like material on ocular structures. We know pseudoexfoliation was first described by Lindeberg and then Vogt. There's a mutation in the gene. So I is iridodonesis, M is puermidriasis, P is peripupillary transillumination defect, and phacodonesis. We know there is a lens capsule weakness. The E is enlarged cup and disc ratio. There are a lot of patients who have 50% patients have glaucoma, and regular cardiovascular assessment is recommended for patients with pseudoexfoliation, as many patients have myocardial infarction and cerebrovascular accidents. So significant refractive and ocular residual astigmatism is found in pseudoexfoliation. Toric IOL implantation with phaco trap can be considered for patients with pseudoexfoliation cataract with astigmatism and glaucoma at the same sitting. before I share my study, I will tell there are some pre-op indicator of jonular laxity which we have to evaluate. Like we all know, there is shallow ACD with normal or long axial range. In supine position, ACD depends and there's a gap between lens and iris, non-dilating pupil, pseudoexfoliation endothelium. These are the pre-op indicator of jonular laxity. There are the intra-op indicators also. And there are some intraoperative techniques we should consider it, like more corneal incision, chopper is held at incision site to prevent iris prolapse, CTR can be used, iris retractors, ring dilators, pupil expanders, and never a tiny rhexis as patients are prone to capsular phimosis later. If there is the point is, if there is a progressive weakness of the jonules, yes, then it may subluxate or dislocate. Then whether monofocal IOL or toric IOL, any IOL will subluxate. Then why deprive the patient from toric IOL and its advantage? This is a very small video clipping. I am showing we have done a partial thickness triangular scleral flap which we make for trabeculectomy. Toric phaco is done, routine phaco, and then toric IOL is being implanted. Now the trabeculectomy punch is being done. And it is sutured and the conjunctiva is also sutured. It's a usual case. This is the 6 years follow-up, and you can see a very mild phimosis-like effect is there. You can see this is the 6-year follow-up. The IOL is at the same axis, 94. So we did a study, comparative analysis of refractive outcome of toric IOL in post-combined surgery SIA group and post-phacos SIA group in pseudoexfoliation cataract with glaucoma and astigmatism. These are the inclusion and exclusion criteria. We took astigmatism more than 2 diopter. We did not take any jonular laxity patients, no pre-op and intra-op sign of jonular dehiscence. This is the prospective randomized comparative study. Single surgeon tertiary care hospital in group 1 40 eyes, group 2 again 40 eyes, group 1 toric IOL power with post combined SIA group and toric group 2 toric IOL power with post phaco SIA, which we normally use. So based on centroid value, SIA was calculated for both the eyes. Post phaco trap SIA was found 0.21 and left eye 0.23, and post phaco SIA was 0.5, which was added in toric IOL power calculation for group 1 and group 2. This is the pre-op data of all the eyes, the age, sex, spherical equivalent K1, K2, and axial length. It was comparable. The outcome measures at 90 days were photopic and mesopic UCDVA, BCDVA, spherical equivalent, intra and intergroup anterior chamber depth, and residual astigmatism. The comparative analysis of pre-op and 3 months post-op anterior chamber depth in group 1 and group 2 was comparable. The intra-group comparative analysis of pre-op and 3 months post-op anterior chamber depth in group 1 and group 2 was also comparable. This is the post-op spherical equivalent, which showed a significantly better result in group 1, that is toric IOL power with post-combined surgery SIA. Post-op IOL rotation was comparable. Post-op residual astigmatism showed significantly better result in group 1, that is toric IOL with post-combined surgery. Photopic uncorrected distance visual acuity, photopic best corrected distance visual acuity, mesopic uncorrected distance visual acuity, mesopic best corrected distance visual acuity, all were significantly better in post-combined surgery SIA group, that is group 1. So the conclusion is significant refractive and ocular residual astigmatism and open-angle glaucoma is found in pseudoexfoliation syndrome. Cataract surgery with trap results in unpredictable astigmatism due to scarring at the trabeculectomy site and making it difficult to reach zero error with simultaneous toric IOL implantation. But this study adds that after adding post-phaco trap SIA, we can implant toric IOL at the same sitting with phaco trabeculectomy, resulting in optimum refractive result. Thank you.
Very, very interesting concept where you can actually.
Yes, because
do the
whenever
SIA post-trap.
there is in all the debates, as I am chairman scientific committee, Jharkhand Ophthalmological Society, there we conducted a debate, and in that debate we have very good results with this. But everybody was saying, no, don't do this, don't do this. But then we had to prove, then we took out all the data, calculated it, and found that this is that.
The results are much better
Yes.
when you include the SI.
Yes,
Well
yes.
done, ma'am.
Madam, can I ask one question?
Yes. I mean, because I did not take any.
I think she wanted to.
With the posterior optic capture.
But I did not take that case now. There's an inclusion.
Why? Sir, why, sir? Why do you do that?
General.
No, but then if you put it in the circuit,
But we have done so many hundreds of these cases, and nothing happens.
Yeah, I have
thank
one.
you very much.
Yes,
ma'am.
One-
Dr. Sentin.
Sure.
Yeah, regarding these hard cataracts and intumescent cataracts, the femtosecond laser cataract, is it advantageous?
Let's
Maybe
discuss
the
that
users
over
of
dinner.
femtosecond. How exactly?
100%, because the problem is the advantage, the Rexis is done, the segmentation is done. In Catalyst, we have got 8 segments, softening of the thing is done. The pre-cut, it's like a pre-chop. So all the way down it cuts, and the Catalyst is definitely a more powerful machine than LensX and other machines as well. So the amount of phaco energy which is used is very, very less. So my femto cataracts, especially hard cataracts, my femto, the corneas are crystal clear when
Excellent.
compared to the manual phaco.
We now invite, let me invite you to give you.
Sorry.
I'd like to now invite Dr. Mohan Rajan to give his talk on the proactive management of chamber stability with advanced fluidics.
Thanks, Suvira. Thank you, AIOS, for the wonderful opportunity. This is about, I'm talking about the proactive management of fluidics. Is very, very important. Yesterday, when the live surgery, somebody was asking me which machine is the best. In my opinion, all the machines are best, but certain machines have definitely got an edge. The Stellaris Elite PC. Elite means the latest version of this thing, and PC is procedural choice. So if you see this cataract, you can see it's a grade 3 cataract I'm doing here. And I've done a Rexis, I use my chopper. There are many ways to skin the cat as far as hard cataracts are concerned. This is a sharp chopper, it's called Mohan Rajan chopper. Appaswamy makes it, I don't have any financial interest. The 1.75 chopper which I use normally. For black cataracts I use the 2mm chopper, and you can see here the whole thing. Okay, it not only occurs, it's called quick chop express, occurs very fast. I do the vertical chop. You can see the chamber stability is fantastic because it's a true venturi system. That's the beauty of this Stellaris machine. And every time I come out of the eye, I press the cotton bud, which I mentioned in the 2-minute video contest as well. And then I go ahead and put a Luxmart toric lens, and this is my choice as far as the EDOF lenses is concerned. And the Luxmart is a fantastic this thing. Just to show you, and from Bosch and Lomb, it's capable of not only phacoemulsification, but it also has the vitrectomy system as well. The advantage of the Stellaris PC Elite is a true venturi system. Another advantage is you saw that the chamber was so stable despite the fact that I was using about 600 millimeters of vacuum. The dual linear capacity, the attune energy, the DICT, the dynamic infusion compensation technology, wherein automatically, because of the adaptive fluidics, you can see here, the chamber automatically gets stabilized. The intraocular pressure is continuously monitored. So you don't have to, and you don't have to bother about the chamber stability. You don't have to bother about the intraocular pressure. Similar to that. And this machine is actually a workhorse and across all types of cataracts, whether it's grade. So I'm going to show you this adaptive fluidics. How it integrates the precision aspiration control with the DICT, which is called the dynamic infusion compensation technology. It creates a new standard for stabilizing intraocular pressure. The DICT, as I told you, is really fantastic. You can actually close your eyes and operate in a Stellaris PC Elite. Only thing is the patient should not close his eyes. That's very important. Again, because it's so stable, this chamber is so stable, you don't have to, in a peristaltic machine, normally when you are on about 40 ml per minute aspiration flow rate, when you are taking the last piece, you need to reduce it to about 20-25 ml because you don't want that flow rate to come and the PC to come forward. So that the surge can occur. But in the Venturi system, especially with saying attune energy, and that is the biggest advantage of this. The adaptive fluidics is something which is unbelievable. It's incredible way of handling the intraocular pressure. Because the pressure, sometimes the gravity fluids, what happens is you keep it at 80, 100 centimeters. You do not know how much of intraocular pressure is going. A more amount of height, more amount of fluid going into the eye. If you see this corneas post-operatively, the corneal edema will be more. Okay? Because it washes away a lot of endothelial cells as well. So it's not now the new, the concept is to have a little lower bottle, like even Centurion, I have a bottle about 30 millimeters of mercury or intraocular pressure, that what's called the target IOP. So again you can see here this another mission. I will not mention which mission is it, but it's a very top end mission. Okay, it's a peristaltic mission. So I'm going ahead with the phaco. It's uneventful this thing, and you can see this is a fairly hard cataract. It's a grade 3. I'm chopping. I'm using my chopper, vertical chop. Okay, unlike RP, he does a combination of horizontal and vertical chop. I do vertical many ways. You can see what is happening now. Last piece I'm taking, see what is happening. Can anybody tell me what has happened? Surge. Surge. It's because of surge. PCR has occurred. Immediately I brought it up and in front of this thing, injected viscode into the anterior chamber, and then rest is how I manage this patient. That's a different history. I want to show you how this surge can produce a problem in a PCR, especially when you are removing the last nucleus piece. And that's what I think the attune energy management is something which is anything. If you see it's like a piece of granite, this hard brown cataracts, which are very common scenario in our country, in our setup. And if you do a conventional phaco with this thing, without any cold phaco technology, which is there in the Stellaris PCA light, you can have a white cornea like this. And you can see many of these corneas can clear up, but the problem is 25% of the cases can have cystoid macular edema as well. So that is what is called the hyperpulse, which is there in the Stellaris PCA light. So this is the continuous mode. If you see of the continuous, we do the continuous mode, what happens is there is not only lot of phaco energy which is released into the anterior chamber and to the endothelium as well. There's also a lot of chatter. So what happens is the nucleus gets chattered, okay, and from the thing, and every time it moves around in the anterior chamber, there's a lot of turbulence in the anterior chamber, and that's why you get this white cornea, so the corneal edema. See this hyperpulse. The hyperpulse, what happens is you can reduce the pulse thing to as less as 4 milliseconds. And during the on time, it cuts the cataract. During the off time, it sucks the cataract. And cools the tip as well. And that is the beauty of this cold phaco technology. You can see here, this is, tell me when time is over, because if I give the mic to me, I'll keep on talking.
The bell will ring, sir.
Yeah, I'm just going to show you a couple of videos. You see this brown cataract, okay? Grade 4, grade 5. When I presented this, the ASR, Howard Fine was the same in the instruction course. Unfortunately, he passed away. He said this is grade 13 in US. Okay, I told him grade 4, grade 5. In grade 13, we never see cataracts like this. Okay, and he practices in Washington State, in Oregon State, where only California cataracts are there. You can see here, I'm going bevel down in the Stellaris PC machine. You can go bevel down because this thing is so fast. The vacuum buildup is so fast. In Venturi, you don't have to go like the peristaltic. In peristaltic, you need occlusion of the tip for the vacuum buildup to go up. You see that, we hear that mission sound, but you don't. In Venturi, it is not like that. There's no aspiration flow rate here. It's all vacuum-based system. That is the beauty of the system. You can see here, because I'm using for the vitrectomy as well, you can see here how I'm cutting the cataract into smaller pieces, how my chopper works like magic. See, I'm using an 1.75 chopper, and you can see here how beautifully it works and how I'm cutting the cataract. The only thing is you need to make sure the posterior nuclear plate, but rest is so easy once you cut the cataract into smaller pieces. The dual linear is another beautiful advantage of this mission. You go to the yaw and go down. You can simultaneously increase the vacuum, you can increase the number of pulses, you can increase the phaco power as well. See, this is a black cataract of Niagara. You can see here, I'm making a deep trench there, and you can see the parameters which are there on the left top this thing on the screen. You can see here how I'm chopping that cataract. I'm making sure that I open up the posterior nuclear plate. It is very, very important for you to understand this whole ball game and how this vacuum, because the holdability is directly proportional to the vacuum, and you can see how I'm holding that right piece and how I'm using the left hand. Make sure the chopper is directed directly towards the optic node. Don't drill the chopper. Keep the chopper right in front of the phaco tip there, and you can see how the chopper works wonderfully like this. I'm using a 2 millimeter chopper in this black cataract. 2 millimeter chopper is also multi-purpose. If you want to stab somebody in the abdomen, you can use that 2 millimeter chopper as well. So you can see the rock art cataracts. Pristine wound, pristine cornea, clear corneas, day one, especially when you're using premium lenses. All these, and again, pneumatic vitrectomy system, 20, 23 gauge, 25 gauge, 27 gauge, which we are using 15,000 by blade, and again, the advantage is of course, I'm stopping. Thank you very much. And for people who are here, postgraduates and practicing ophthalmologists, please email to me if you want this book. 2 books I'll send you, Cornea Atlas and Retina Atlas, drmohanrajan@gmail.com. And this offer, I want this offer from you. Thank you very much.
Hello. Anybody over here? Sir, few comments on peristaltic versus this Venturi system.
Yes.
Anybody knows the evolution of Venturi system? Anybody has the idea of how Venturi system was evolved? And there were 3 pumps when phaco machines manufactured.
Diaphragmatic pump was also there.
Diaphragmatic is the best pump out of all 3 pumps. The first is diaphragmatic, and the Stowe's people came out with diaphragmatic pump. Has anybody seen or worked with diaphragmatic
Long
pump?
time back we had one machine.
Yeah, it is very noisy.
96,
It's a very noisy machine. So the Stowe's people manufactured 2 machines, one with diaphragmatic pump and another with Venturi pump, Protege. So, but diaphragmatic pump, they pushed Venturi pump very, vigorously. Diaphragmatic pump was making very noise, but all the machines were patented. So another big company was not able to manufacture anymore of Venturi pump. So they propagated peristaltic pump, and all PCRs what we are seeing, and anterior vitrectomy and so many things we are learning. Instead, I think personally, if we just switch over from peristaltic to Venturi pump, lots of things you need not to learn about anterior vitrectomy and so many. I really want to know from the audience how many people are using Venturi pump, Phaco machine. Not a single person. The moment you turn your peristaltic pump to Venturi pump operated phaco machine, you will forget to know how to do anterior vitrectomy. Believe me, this is my personal experience. I am in phaco, I'm doing phaco since 1996 onwards. I had 3 different machines, and the moment I purchased my Venturi system, I hardly know I might have disturbed PCE in maybe 5 or 10 cases in my 25-30 years of career.
Very fast.
Sir, it is. No, that is the myth which we have been taught, sir.
No,
that is the myth we have been taught. I am very much against this myth, sir. The moment I shifted to peristaltic to Venturi machine, I regretted why I did for 7 years use my peristaltic pump. So the basic most basic pump operated Indian company from South India came with Venturi pump machine. I used that machine. Every machine, whether it is a 5 lakh cost machine or 50 lakh cost machine, will give you the same result. Believe me, this is my personal experience I'm sharing with you.
I have to only fully agree with Mukesh, because it's fantastic to use the thing. The older concept was the peristaltic gives you time. It's a forgiving machine. I don't think so, because all the peristaltic machines are mimicking the Venturi. All the Venturi machines are mimicking the peristaltic. So they are more or less same. No, I have the Veritas.
We will come to our next speaker. Next speaker.
Dr. Mohan.
Thank you very much.
Dr. Mohan, may I?
Literally telling, please get out.
Okay, sir, thank you. Okay, next presentation.
It's really amazing to listen Dr. Mohan Rajan. He's a extremely very nice speaker and orator of the subject. So we really learn a lot of things from him.
Okay, sir.
So thank you very much, Mohan Rajan, leaving the podium.
Okay, next topic is aligned chopping in hard cataracts by Dr. Dharmendra Nath.
So this is a new technology for the hard cataracts to chop.
Can we please listen
And
to Sir speak?
Yes,
Thank you,
yes.
everyone
This
in
is
the
a line
audience.
chopping. So you have come to know about the Mohan Rajan's chopper and Rajendra Prasad terminal chop, and this is a different kind of chopper. So there are so many techniques altogether. We are not going to discuss all these things. Two main categories are there. So basically we are doing the horizontal chopper and the vertical chopper. There are a lot of differences. I don't want to enumerate these things because you all know why this aligned chopper come into action. Because most of the time when you just hold the nucleus in the center, that spins around the axis of the phaco tip. That is the main problem either with the beginners or with the specialized surgeons also. So it spins. Just see this again, and we just hold in the center and we try to chop it. Once we go from towards the periphery side, we want to try to chop, and it spins. And it breaks. It doesn't chop actually. You see, there is a break. The fibers, they are all attached together. So the concept of the aligned chopping came to my mind. If I just aligned this chopping technique towards the centripetally, I can do something better for it. So I designed a three-dimensional chopper. This is all the choppers or the hooks, they are two-dimensional. This is three-dimensional. It is a blunt at the tip, 1.5 to 2 millimeter long. Bend is 30 to 40 degree and 2 millimeters away from the blade. 26 gauge soft. Now you can see this is a three-dimensional. There is an angle of 30 degree, 30 to 40 degree, according to whatever you accepted. So this is a aligned chopper. Now see this. Now, hold in the center, go into the periphery, and you chop. Just see, the clean cut is there. And anteriorly, it is a chop, posteriorly is a separation. Again, you rotate with the same, hold in the center, and go to the periphery, and chop towards the tip. And it chops. It doesn't allow the segment to rotate. Hold it, the apex of the pie, and separate it. Just see how the classical line of cleavage is there. There is no fibers there, so there is no crushing effect. It is only the chopping effect. So that's why it is a chopper. So multiple pieces by this we can do it, and if you do the multiple pieces, 8 pieces or 16 pieces or more, less energy, less damage to the endothelium is there. Now, basically always make a big CCC in hard cataracts. These are the basic and fundamental rules. Make a good crater and see this. Hold it with a high vacuum and go along the course of the curve of the chopper. This is very important. You are not going to straight inside you have to go. You have to follow the curve of the course because it is three-dimensional. And just see this, go to the periphery and pull towards the center. Centripetally, it just chops anteriorly and breaks posteriorly. And the angle of the chopper helps in lateral separation of the heminuclei. Hold again, go to the periphery and chop it again. We can rotate easily and you can do the multiple chopping. Just see the soft and a little hard cases. You can do the vertical chopping as well because they are the two designs. So one is the sharp chopper, one is the blunt chopper. So sharp chopper can be used and you can very easily, you see there is a clean cut cleavage is there. That is the main beauty of this chopper. And see this, you will be able to appreciate how it's going on. Hold in the center, the white cataract. and going to the periphery, take the chopper towards the periphery, and see it's coming in the align, and it chops in two halves. And then after you can do the multiple pieces of it. And if you are a femtophaco surgeon, and see this, you can do it, take out the button, gentle hydrodissection to take out the bubbles. This procedure has to be very much gentle because you have already making a softening of the nuclei, you have done it, and see the rotation. Bubbles is coming out from behind. Go in. So here it is very important to position the nucleus. Just going in and position it so as to hold it nicely, rotate it a little, and this is how the lid separation is done. Thank you very much.
Excellent presentation. I must try your chopper too. Interested already. I'd like to now invite Dr. Chitra Ramamurthy, who will present her paper on phaco in colobomatocytes. Sure.
The only problem, of course, we've done it so well, and even RP also showed that. The only problem with the horizontal chopping in hard cataract is that in horizontal chopping, you have to go underneath the rexis and come from the periphery, from the equator. The problem is these cataracts have nucleus and more nucleus. There's no cortical cushion. And especially when you have a small rexis and a small pupil, it will be a little dangerous to do it because it's a blind technique. You're going underneath and coming from the periphery. Whereas vertical chop, you use a sharp chopper. Horizontal chopper, use a blunt chopper. Vertical chop, use sharp chopper like my chopper. But you go in right in front of the rexis margin, like what I showed. In front of the rexis margin and chop straight away. It's called a vertical chopper. So that is actually you can various types of cataracts it will work, various types of pupils it will work. And rexis, again, horizontal chopping, little larger you have to make. You don't want to make it very large because if you want to put any multifocal lenses, you don't want 5.5 or something like that.
So one question to Dr. Sir. So is it necessary to always rotate the nucleus after femto laser?
Yes, you have to position it.
Position it. But you,
So that you can hold it and you can separate it.
correct. Thank you, sir.
Thank you very much, moderators on the dais. I might do the next few minutes to talk about
cataract surgery in colobomatocytes. Now, coloboma and cataract may not be just very straightforward. It could be associated with a microcornea, a poorly dilating pupil, there could be zonulopathy, there could be hard cataract, there may be posterior segment anomalies. Now, often enough in colobomatocytes could also be associated with microphthalmus. Now, if it's a simple microphthalmus, it will be 2 standard deviation less than normal, that is less than 21 millimeter axial length. But it could be a complex microphthalmus when it could be associated with anterior segment dysgenesis, retinal dysplasia, or persistent fetal vasculature when the prognosis becomes different. So pre-operatively, when you're looking at these eyes, you have to first look at the microcornea, measure the horizontal corneal diameter, which is going to be a prognosticator of how the surgery is going to proceed. The anterior chambers may be shallow when you may have to decongest the vitreous. You would have to look at the pupillary dilatation and plan on using iris hooks or pupillary dilatation devices. Grade of the cataract would also have a big significance because if it is associated with the microcornea, you might even plan an SICS. Phacodonosis, the amount of dialysis would decide how you're going to take the surgery. If it is associated with strabismus or nystagmus, you would have to visually prognosticate and inform the patients, and of course if the fundus cannot be seen, a B scan is needed, and IOL power calculations are more complex, so you need to use the 5th generation formula. Intraoperatively, if it's a microcornea, even the wound creation has to be planned. We have to factor the low endothelial count, which is often seen in these eyes. Enough viscoelastic angle crowding has to be featured, and we have to think of glaucoma and use appropriate steps. And pupillary dilatation in asymmetric pupil, increased risk of iris prolapse has to be factored in, so the eye has to be softened before the surgery. And in the area of dialysis, as I'm going to show you, in the area of coloboma, there could be a rexus tear, there could be fluid misdirection in these eyes, there could be even suprachoroidal hemorrhage and an expulsive hemorrhage in these eyes. So do I do a phaco or an SICS is the next question which would come up. Any eye with a corneal diameter of more than 8 millimeters, a closed chamber surgery like phacoemulsification makes sense, is what this paper suggests, as do many other papers. But if the corneal diameter is 6 millimeter or less, it seems to make sense to do an SICS, and keeping in view that some of these eyes could be associated with a whole lot of retinal problems. So this is just one flow chart which they have created based on the corneal diameter and a very small cornea and a severe cataract and significant dialysis, and of course the surgeon's experience kept in mind. You would have to take a call whether it's going to be a phaco or an SIC surgery. Now running you through some surgeries. Now this is an asymmetrically dilated pupil. Placing iris hooks makes sense because then you could center your rexus and get a more optimal overlap of the rexus over the IOL. And then in that area of lens, it's not just an iris coloboma and not a lenticular coloboma, but you need to fashion out a centered rexus, keep in view that you do not have any radialization. A gentle hydro, these are small eyes, decompress the eye, and then ensure that you have a free rotation of the nucleus. This is a fairly dense cataract, so in these cases I would prefer to make a small trench in the center so that it gives me a good purchase on the nucleus, and then just go ahead and do a one chop, and more often the chop would come through and through, but there could be times when the chop may not happen through and through, when you could go and do a further lower level chopping and a sub chopping. But the idea here is, because of the smallness of the eye and the shallowing of the shallow anterior chamber, it sometimes makes sense to get them into multiple small pieces, or if it is one piece which has got loosened, get it out. Like it's like opening up a jigsaw puzzle, and you get that piece out, you have created more volume in the eye, and then you can lower the IOP as those fragments become fewer and smaller, and then remove the cortex and place the lens. Now this is a case of a lenticular coloboma along with iris coloboma. So first and foremost, a careful wound creation. You go and plug that area of dialysis with viscoelastic, because the anterior and the posterior chamber are connected. There could be a fluid misdirection. Do not overinflate these eyes, just adequate viscoelastic. Sometimes it even makes sense that you do not use the tryphen blue right away, because the tryphen blue can go behind and you could lose your red reflex. So they even suggest that you could inject viscoelastic, flatten the cornea, get your and then wash it off and then stain it, so that at that point of time you are able to get a better access. And you need to keep grasping and re-grasping, because there's some amount of pseudoelasticity because of the lack of zonules there. In this particular case, I've just done a straightforward stop and chop procedure and actually tried to get these pieces a little supranuclear with adequate viscoelastic coating the endothelium, keep my parameters low. I would be conscious that my parameters are low so that there is no fluid misdirection which happens in these eyes, which is a challenge. So keep going back and injecting viscoelastic to plug that area of dialysis. And at one point of time, as I'm removing the cortex, I feel there's a tug. So there could be a vitreous coming in. So I would place my CTR. It's better as late as possible, but it should not be later than it should be. And this is a case of an asymmetric, lens coloboma. So I'm here creating an Hoffman's pocket, and then just adequate viscoelastic, and of course to plug that area of absent zonules and create my rexus well away from the area of zonules. It's very important to decenter your rexus, because as you go closer, you could have a radialization of your rexus. It's a fairly soft cataract, so there's not much. Otherwise, I would have actually advised placing a CTR before doing your manipulation, because of soft cataract and very controlled fluidics, we could go ahead and do it. And then I place my CTR, and of course always dilate so that the long arm of the CTR comes to overlie the area of the dialysis. Now, probably this is all that is needed, and IOL could have been placed. But the idea why I placed a CTS was, there is some amount of zonular absence. It's not a progressive zonulopathy, but there could be an asymmetric back contracture, so it makes sense to me at that point of time to place a CTS and then suture it and get a symmetric eye. Now this was a case wherein I did it on the femtocataract platform. There was a sub-incisional coloboma in the size. Now the advantage of using a femtocataract is you get your X's right, you don't have to be worried about the radialization, and even if it's a dense nucleus, you have all the grooves and the fragments done, so the manipulation in these small eyes is so nearly nullified and becomes a fairly straightforward case as against how it would be in a shallow anterior chamber and a small eye. And then but the removal of the doing the surgical per se is not, but I do inject viscoelastic to plug that area in the subincisional area, nearly finishing, and then I eat up the entire nucleus. But the one thing what happened was, as I was, after removing the nucleus, I felt that I could not go on to the cortex straight away. I felt there could be some vitreous coming in, and then I inject diluted tricort. I see some vitreous stand, so cut the vitreous, do a little shallow anterior vitrectomy, and then remove the cortex and complete the case. Now this is the last case where the cataract is quite dense. So you know the pupil is also not well dilated. I've given mannitol, create a large SICS, and as I create my inject adequate tryphen blue, I keep retracting the iris and make my rexes. Not able to fast forward. Make my rexes because I need to have a fairly large rexes because often the extent of the cataract is so dense and so large in these microcorneas and very shallow anterior chamber. But however, it was not that much of a challenge and I get the nucleus out. Now this is the last situation wherein things appear fine, but it was a microcornea, coloboma, hazy cornea, black cataract, and I decided that ECC is the best way. I have given nil prognosis to this patient, one eye is already gone, and then as I I can see that air bubble going in, so that's an area of dialysis, and a large can opener was actually done, and Vectis was used to get the nucleus out, but at the last minute, the nucleus dropped, and then we had to, it became quite a bit of a challenge. So this was a paper, seemed to be very relevant. There were 15 eyes of 15 patients where actually the zonules were broken and the lens was dislocated in the vitreous in a very controlled manner. And they looked at the results of these 15 eyes. The vision, CDVA actually improved. There's just a transient increase in IOP. And they even wondered whether couching of an intraocular lens in these very severe microphthalmic eyes with iridofundal coloboma probably could be the way to go. So I would like to conclude stating that iris with coloboma, doing a phaco or any other procedure in these eyes, these challenges have to be kept in mind. Thank you.
Thank you. Can you turn that on? So I'm here to share with you my so-called cumulative experience, and I'm not sure how to share my cumulative experience in 7 minutes, actually 7.5, but I'll stop at 7. Okay. All I'm going to show you is 3 or 4 surgeries and tell you what I think works and what doesn't, right? It's not too much or too intensive. The problem with polar cataracts is we all know you get an abnormal adhesion between the posterior pole of the nucleus and the lens. Not only that, you've got an abnormal fragility of the posterior capsule. Typically, a tear in the polar cataract, as you can see here, occurs as some sort of an intraoperative manipulation unless it's present before. Despite doing a viscofluid exchange, how do you know that there is a disturbance in the vitreous? You saw that the tear in the typical spindle-shaped tear became wider. It's always wise to delineate this vitreous that is disturbed. The triamcinolone alone doesn't stain it, it sticks to it thereby delineating it, and therefore you can make sure therefore that you do not end up missing on any vitreous. The other thing is that often the triamcinolone alone goes and stains the vitreous within the posterior segment too. It's important to note that we don't keep cutting the vitreous. You cut it first within the incisions, in the AC, in the area of the pupil, and finally in the area of the rent. Once you see the rent coming back to its normal size, you perform a viscofluid exchange. And all of us need to learn, and if you haven't, you must, even in your normal eyes, learn how to place a 3-piece IOL after making your incision to about 3.4 millimeters into the ciliary sulcus. There's no question of ever putting a monofocal lens in the sulcus. Put a 3-piece lens, preferably. I haven't done it here, but you should do a posterior optic capture. Thereby, you don't need to actually change the IOL power either. Now we know that we can have tears. How is it that we can avert a vitreous disturbance in a patient with a polar cataract, typically I have found, despite my low flow settings, and I am one who feels that peristatic machines actually give me the possibility of doing that. Typically, when you remove the endonucleus, and even more typically when you get to the epinucleus management, you'll see this, there it is smiling at you, the tear in the posterior capsule. What's important then is we don't panic and pull our instruments out of the eye. The gold standard in managing any PCR or a PCR that you see in a polar cataract is not letting the chamber shallow. If you can just about manage to not let the chamber shallow by bringing the source of irrigation, which is the phaco probe, out of the eye, by performing a viscofluid exchange, and I typically like to use a dispersive viscoelastic before I bring the probe out of the eye. Then I find, once I put in a dispersive viscoelastic, 9.5 out of 10, I can still use a bimanual irrigation aspiration to remove the cortex, even if I have a PCR, except that when I'm swapping my hands, I will then again do a viscofluid exchange before swapping my hands. In this interesting case, note I've actually got a partial tear. It's not gone all the way to the other equator. Now, when you're left with a situation like this, polar or otherwise, you have to stabilize the opening before you do anything else. So with the help of an intraocular forceps, even I was surprised, this was my first, wherein I just converted it into a stable opening, after which then you have an option of either putting an IOL in the bag or putting in the 3-piece IOL in the sulcus. I think I managed to put it in the capsular bag here, I think so. Yeah, no. It's in the sulcus, and now I perform a posterior optic capture where you just dip each side on either side and you've got a stable bag. Now, I think this is just to make a point that it's not over till it's over in a polar cataract. You know, all has gone well here. I'm very happy. Does 2 polar cataracts off in a day. I don't know what's happening in Maharashtra. We see a lot of them. And I put in my single-piece monofocal eye in the bag. I'm happy because it's easier than putting in a 3-piece one. But never, and typically I don't go behind the IOL to wash out visco. I do a gentle rock and roll, and I claim to do a very even gentler rock and roll in a polar cataract. But here, when I'm actually being rather gentle here, and this typically is my slowest step in my phaco. But when I'm just removing the viscoelastic, the mere nudging of the optic posteriorly is enough. Can you see that? There you see. It's actually torn, and the typical spindle is starting out there. So when you have a tear after putting in an IOL, even in a polar cataract, don't worry too much. The point of this video is to let you know that you've got to take utmost care till the very end. Often you may need to even while hydration, you can just rip because of the high pressure there. So it's not over till it's over in polar cataracts. And now the highlight case of mine, if I may have an extra 20 seconds, is the next one, which of course co-managed. I've seen this patient on table, and this is what I find. I don't know how many of you have experienced this. Now here you go, you've got a polar cataract with an existing PCR. Seen typically because we tend to operate them earlier, so you can see through and through, or you can diagnose it preoperatively on UBM. Now I've got a tear, how am I going to manage it? So the same basic principles of management. Low flow settings, I will work with a lower flow rate. I believe there's meritocracy in that. I will use only enough energy that I need to impale the nucleus and bring it up. I don't fiddle around with the nucleus in the bag. I try and hold it and bring it up. Utmost care, there it is, the tear which showed to me even before I started the surgery. Again, viscofluid exchange at every step. I couldn't bring out anymore. And typically for my subincisional epinucleus, I tend to draw it out with my non-dominant right hand. I've brought it up, removed the last part of the epinucleus. The tear is still showing through, but what's important I'm looking for is, has it splayed open more, signifying the possibility of vitreous prolapsing forward. Now actually it is playing a little more, but truly this is a dispersive viscoelastic. And as I told you that once I put in some dispersive viscoelastic, each and every time I bring my irrigation out to the eye, I end up managing quite easily, because removing the cortex with the eye cut mode of the vitrector is also an option, but I tend to be able to manage it with this. If not, I would use the eye cut of the vitrector. Care and caution while removing the last part of the cortex. Again, swapping hands, performing a viscofluid exchange. And whilst this is going on, while it just ends, I think the question often asked to me is, you put this much visco in the eye, what happens to the pressure post-operatively? There is maybe 1 in 2 in about 10 or 20 patients where I may have some corneal edema, So with a little bit of Dimox, maybe a Dimox ER or IPAR SR, I'm able to just tide that over in about 24 to 48 hours. I believe it's a lot better an option rather than having vitreous being disturbed. I guess with that I come to the end of my presentation. I'm happy to talk now. Thank you.
Excellent cases. Excellent performance, Dr. Suvira. One thing which we do is while doing normal cataracts, we have a habit of, dialing our nucleus. But in a case of a PPC, dialing the nucleus is absolute no, because that causes a stress in the zonules as well as in the PC, and the rupture can occur. So this one point we have to keep in mind. So no dialing of the nucleus in a PPC. Nucleus. In a no rotating, yeah.
Hello everyone, good evening. I'll be talking about a term called pupilorhexis, which is novel technique for management of pupillary membrane, which causes non-dilating pupil in especially long-term uveitic cataracts. So the cataract that is caused by chronic inflammation of recurrent uveitis, inflammation leading to the formation of pupillary membranes. Now they cause a very challenging surgery because it causes the restriction of the dilatation of the pupil, hindering a proper visualization and access during the cataract surgery. So these non-dilating pupil, the synecdoche that is caused between the iris and the capsule, it causes the failure to dilate. The conventional techniques often comes handy using iris hooks or rings or pupillary dilators, but they have some limitations and complications associated with these methods. So what is pupilorhexis? It's a technique that involves creating a controlled tear of the and removal of the pupillary membrane. It causes the restoration of the pupillary dilatation by eliminating the membrane's mechanical restriction. So I'll be presenting a case. This is a case 1. I'll just move forward. So this is a uveitic cataract, and you can see the synecdoche all around 360 degree, and there is a membrane. So the key is creating a window between the membrane and the anterior capsule. So you can see I'm making a window between the iris and the anterior capsule with the help of a repositor. And once this window is created, you can separate the diaphragm. Now you can see the pupil is now nicely dilating after the constriction is broken and the membrane is removed. After the removal, you can see a 360 degree membrane. It comes out intact in one piece, which leads to a free pupil that can easily dilate, and we can carry out our cataract surgery unhindered. So the last piece of the membrane is also removed, and here is the intact membrane that you can see.
Very good.
So now the mechanical restriction is broken, and the phacosurgery can be carried out nicely. The rest of the procedure was as usual. There's a second case 2. You you can see I have taken out a piece of the surgery. So the pupillary membrane is being removed. It comes out very nicely once you have a good window and a good hold at the pupillary margin. And the entire membrane can be peeled off like a rhexis is made on the anterior capsule. These kind of pupils, they usually dilate and they respond very well to pupillary dilatation, to adrenalines. And here the intact membrane is removed from the iris. The membrane usually comes off in toto, but sometimes it causes some breakage and you can get a complete rhexis done. Okay, this is the case 3. You can see the constricted pupil. The dye is coming out from, because we inject the dye behind the iris, so during the process some dye keeps coming up in the view. But you can see the pupil is being released slowly after the membrane is released from the pupillary margins. And these pupils, they usually react very well and they respond to the intraocular dilatation. So the key is if we use iris hooks or any dilators while the membrane or the pupillary synecdoche are present, it will cause the breakage of the pupillary margins, and post-surgery you will have a very rigid, a very ragged, very disturbed pupil. And if you use a technique like this and you remove the membrane entirely from the pupillary margins, post-operatively you will have a very nice reacting pupil which is usually free from any of these synecdoche or membranes. And this is the last case. This case was a young male. This was a young male who had undergone a VR surgery. He had undergone VR surgery for RD surgery, then he went on for SOR, but there was some oil remaining in the anterior chamber.
The cursor is not showing.
So this case didn't have a complete membrane, but you can see partially you can see there is a good synecdoche that is present all over, and it had some pupillary membrane fragments along the pupillary margins. So this was causing the undilated pupil, and once you remove these fragments from the pupillary margins, the pupil gives way and it easily dilates. So once I'm breaking the synecdoches and we're removing this pupillary membrane along the margins of the pupil. So they come off very nicely with the help of a rhexis forceps, a microforceps. And once you remove these membrane entirely from the pupillary margin, you have a very good dilating pupil, and your entire surgery does not require any assistance of pupillary dilatation or iris hooks or any dilators. Am I okay? Okay. I've just finished. So this the keynote is identifying the pupillary membrane, distinguishing it from the anterior capsule and the synecdoche, performing a rhexis with a micro instrument, and achieving a free pupil post-rhexis. So this gives you a very easy surgery. We does not require any iris hooks, it gives you a better pupillary dilatation intraoperatively and good visualization of the surgery. Thank you.
So where she gets organized,
Any chances of iridodialysis while you're pulling the pupil?
Next presenter is Dr. Jayashree Pura. Topic is fluid flow issues after posterior capsular rupture.
Should I start?
Yes.
Okay. Very good afternoon. I know this is going to be a little bit of a boring topic after seeing those wonderful surgeries, but my job has been made easier by Dr. Suvira, who has already covered most of the points in this. So we are talking about the condition where you have a vitreous loss, where you have a 40% increased risk of retinal detachment, and you know that a simple surgery can become complex and it may eat up a lot of your time. So we have, what is the role of fluidics in phacoemulsification? As we all know, you have two chambers and you have a membrane in between. So following the law of fluidics, always there will be the flow from the higher pressure zone to a lower pressure zone. And when we are doing the phacoemulsification, we have a negative suction pressure. So the fluid, once the membrane is broken, it will flow. That means the vitreous will flow from your posterior chamber to the anterior chamber. Then again, the next law, that it will follow the path of least resistance. And where is our path of least resistance? That is our wound. So ultimately, you'll have a vitreous loss. So as already discussed, you have the patient-centric causes where you have an inherent PCR, but more important are your surgeon-centric causes where your faulty technique or maybe your learning that has caused a PCR, and more importantly, it is the faulty phaco-dynamics and the psychodynamics that is associated with PCR, because you have a long list of cases and you know that a single PCR is going to kill your time, it will make your surgery complex, and also sometimes what happens, you have a busy OT and on top of that you have lots of people observing you in the OT and you just feel that I need to just finish off the case. These are the cases when we tend to land up more into complications. So it's not that you have created the PCR, but how you manage the PCR that is more important. So every step of our surgery, right from our incision, be it the small side port, which we don't give much importance, but even a faulty side port can lead to turbulence in the anterior chamber. And that can also be a cause of PCR. And even the last of the cases, like we discussed about the hydro, last you're hydrating the wound, a PCR can occur at that point. And sometimes what happens, your IOL just juts out of the injector. You are implanting the IOL, it just goes into the posterior chamber. So we also have to remember that we are always concentrating on the dominant hand instrument, that is our phaco tip. But we have another instrument in the other hand, in the left hand, and we have to be careful about that too. So this is just a video showing the last piece, phacoemulsification. Now talking about the intraoperative situation, how do we deal with it? We may break the capsule, but you have an anterior hyaloid face which is still intact. You have a vitreous prolapse, means that your vitreous has come out from your posterior to the anterior chamber, or you have the vitreous loss, that means it has directly come out of the wound. So what's your response now? There are three responses. You might not realize that you have caused a PCR and you proceed with your phacoemulsification. It can happen when you are learning. You realize, you panic, and you just come out. You don't know what to do. Or you take a deep breath and rethink your agenda, and by using the appropriate techniques and settings in your phaco platforms and all the videos that we have seen here, you can beautifully and easily manage the cases. So now we have a new set of goals. You have to minimize the vitreous prolapse, you have to preserve the remaining capsule, implant IOL, and complete your case. So the key here is avoiding the vitreoretinal traction, because our phaco tip, it is a very good aspirator. It's not a cutter. So it's going to separate your neurosensory retina from the RPE, and this RPE pump pressure is just 0.27 millimeter of mercury, so it's easily overcome. So early detection is best for management, and this Dr. Howard finds 3 hours. Suddenly you find that you have increased space for doing your phacoemulsification. The pieces which were coming through to your phaco tip, it does not flow in easily, and you find some resistance to phacoemulsification, or maybe you can hear even the occlusion sound when the tip is not occluded by your nuclear material. So what do you do now? Just stay calm, go to foot position 1 and stop your phacoemulsification. Signal your nursing team. They should be aware that a PCR has occurred without the patient becoming aware of it. They should know what are the things that you require when you have a PCR. It's not that you have a PCR, then you search for your vitrectomy consumables. So this list has to be there. The vitrectomy kit has to be there with every surgeon performing phacoemulsification, and you also need a standby IOL of the correct power. So suppose the piece goes beyond our territory, beyond the territory of an anterior segment, it goes into a posterior segment, no instrumentation is allowed. It's better you refer your patient to your VR colleague. Just let your ego come down, because this fluid management which we see in the third picture, no amount of fluidics is going to float up your nuclear pieces. This is going to happen in the AC. It will not happen in the vitreous. So now you go slow, go stepwise. The most important thing, maintain the pressure gradient. How we do it? By filling it up with a dispersive viscoelastic, deal with your nuclear fragments, do a good vitrectomy, and implant the IOL. So the most important dictum is don't let the anterior chamber collapse at any moment. Don't take out a phaco tip. We keep on repeating this, but the impulse is always to take out the tip once a PCR occurs. So it's a good practice, maybe for the beginners, that you try to inject, when you are taking out the last piece, you might not have a high-end machine. So try practicing injecting viscoat through your left hand, because this becomes difficult when you actually have a PCR. And another important step is that viscoelastics are cheaper than our vitreous. Like ma'am had said, don't hesitate to put viscoelastics. Don't think about the IOP rise that will happen post-operatively. Even if required, you can go ahead with 2 vials of viscoat maybe, or any other dispersive viscoelastic. So if you are in a doubt about vitreous loss, then triamcinolone is the best option. You need to stain it with triamcinolone because this is easily available and it helps in the easier detection of your vitreous. You separate incisions for your vitrectomy, close your main port when you are doing the vitrectomy. So as regards to whether you go for coaxial or bimanual, I prefer bimanual because here you have the irrigation above and you have the you are doing the vitrectomy out where you have the PCR. But when you're doing it with the coaxial, no, you are hydrating the vitreous. So my preference is a bimanual. Whether you go for a paracentesis anterior vitrectomy or the pars plana vitrectomy, which is more physiological, but you have to do the good vitrectomy. The 2 modes are there in the phaco machines. The main is that in cut IA, you have at foot position 2, you have the cutting. Okay, so now when we are doing the cut IA, we have to give the maximum cut rate that is there for your machine. For your conventional machines, it is 1500 to 2500 cuts per minute. But with the newer phaco machines, with active fluidics, you can go up to 5000 cuts per minute. So this is anterior vitrectomy going on, and this movement of the vitrectomy port is allowed only in foot position 2 when you are doing the cutting. So
thank you, Dr. Jess.
Okay,
we'll
thank
wind
you so
up.
much. Yeah,
Okay.
it's just over. IOL implantation is done, post-operative course, and
Thank you so much. Excellent presentation, Dr. Jayasri. Very interesting videos.